So good morning, everyone. Thank you so much for inviting me to talk at your conference today. It's a real pleasure to be here and to speak about postnatal depression, which all of us working in primary care have come across naturally in our jobs. So what I'm going to talk about today is some of the common perinatal mental health problems that we see. I'm going to talk about some of the risk factors that might make women more vulnerable to developing an episode of postnatal depression. Then we're going to talk a little bit about postnatal depression itself, referral pathways and treatments and interventions. So first of all, I suppose just to say that, the term postnatal depression is very well accepted by women and by health professionals. But I suppose we need to perhaps start moving past that now, because postnatal depression is not something that just occurs in the postnatal period. So women become depressed in pregnancy, women become anxious in pregnancy, and women have mental health disorders. And what we do know is that for about a third of women who do develop what we call postnatal depression, they will have had symptoms in pregnancy. So we're moving now towards the term perinatal depression. And the perinatal period, as you know, is from the time a woman conceives up to 1 year postpartum. So we're starting to kind of move towards that, the name of, I suppose, perinatal depression, and perhaps moving on from postnatal depression as we go forward. Women also experience other difficulties, adjustment. So having a baby, massive life change, huge impact on your relationship. So there's certainly a period of kind of postnatal adjustment there as well. Women experience depression, as we said, both antenatally and postnatally. And women can also experience anxiety disorders. So, for example, obsessive compulsive disorder, which is an anxiety disorder where a woman might get repetitive obsessional thoughts, images, or urges, and she might use compulsive behaviors to kind of neutralize that anxiety. Very commonly what we're seeing as well is generalized anxiety disorder, and the worried person who's always worried. If you ask some women about worry, they'll say, well, I've always worried, I can't remember a time when I didn't. And we also see women with, for example, post-traumatic stress disorder as well. And PTSD carries a lifetime prevalence of about 10%. So lots of women are coming through our services with PTSD before they've given birth. We also see a small number of women with serious mental illness as well. So again, using the term kind of perinatal as opposed to postnatal, we're now kind of focusing on kind of perinatal mood and anxiety disorders. And, they're very common. So if you look at the sort of mild to moderate mental health issues and adjustment disorders, they're very, very common. I mean, that's our bread and butter, and that's kind of the vast majority of women that we would see coming through, certainly the Rotunda services, and you'll be seeing these women as well. A smaller number of women might then have sort of severe depression, and an even smaller number might have serious mental illness like bipolar disorder, schizophrenia, or psychosis. So what might make a woman more vulnerable to developing postnatal depression? Well, remember that mental health is biopsychosocial. Okay, so those risk factors come biologically, psychologically, and socially as well. So the biggest risk factor really is having a previous or a family history of any mental health difficulties. Women who develop anxiety or depression in pregnancy, women who experience a traumatic birth, that can be a risk factor. We know as well that for women who are single parents, or as you know, with low social supports, they can be more vulnerable. Women in violent relationships, and also where a woman's had maybe recent adverse or stressful life events. So for example, a bereavement, the loss of a job, the loss of a home. Teenagers can be more at risk as well. And I mean, I'm sure you see this as well. It can be quite difficult to engage teenagers into services. And women who have a history of kind of early childhood trauma or interpersonal trauma may be more at risk as well. And also where it's perhaps an unwanted pregnancy. So if we look at what we call postnatal depression or perinatal depression, we're looking at kind of perinatal mood disorders. Okay, so from the blues to postnatal depression to postnatal psychosis, we have to kind of think of it as a spectrum. You all see women with the blues. It's normal. Probably about 80% of women will experience this, usually in the first 2 to 5 days after delivery. So a woman might feel tearful, emotional, a little bit overwhelmed, but it's transient and usually it passes within a few days. And what's the difference between the blues and postnatal depression? Well, the blues should resolve within 2 weeks of delivery. So if the blues haven't resolved within 2 weeks of delivery, then that's not the blues. That's perhaps leading into a postnatal depression. Postnatal depression, as you know, is very, very common. My slide says 13% of women, probably it's a bit more like 15% of women will experience postnatal depression. And the symptoms, as you know, would be, a pervasive low mood lasting longer than 2 weeks. Anxiety is very commonly a symptom of postnatal depression because it can often be comorbid with depression. And women can experience insomnia, they can experience, suicidal ideation, having no energy and having fatigue as well. And the symptoms can be mild to moderate. It really, really is a spectrum. But I suppose the longer the course of the illness, the longer it takes to get a woman well again. And at the other end of the spectrum, you've got postpartum psychosis, which, as you know, is very rare. It affects about 1 to 2 women per 1,000 deliveries. And it's a psychiatric emergency. A woman might present with kind of bizarre or irrational ideas. She might present as quite manic. She might be hallucinating or experiencing delusions. And that's, as I said, a psychiatric emergency. And I'm sure as public health nurses, you're probably seeing this more and more because the 5th day postnatally is actually the most common day for symptoms of a postpartum psychosis to start, but they can come anytime in the first few months after delivery. And of course, women with a history of bipolar disorder can be at higher risk of developing a postpartum psychosis. So what do women say about postnatal depression? How do they feel? Well, often women will feel very anxious. It's not just depression. It's not just a low mood. Women might have obsessive or intrusive thoughts. And I suppose we have to be very careful about recognizing the normal intrusive thoughts that women can experience. And I spend a lot of time kind of speaking to women about this, both in pregnancy and in the postnatal period, because about 100% of women will experience intrusive thoughts in that early postnatal period. I did, and, they can be quite often sort of based around the safety of the baby. So, for example, thoughts about maybe dropping the baby down the stairs or what if I was standing beside the kettle and I burnt the baby with the kettle, these types of thoughts, but they're very, very common. And usually for most women, those kind of intrusive thoughts usually resolve within those first few weeks. But women with postnatal depression can have really distressing intrusive thoughts that don't subside. Women can feel like a failure. They might experience symptoms of panic, feeling like somebody's sitting on their chest or feeling, that feeling of dread, like something's going to go wrong. They might feel rejected. The baby hates me, my partner hates me, my family hates me. And they might feel very distressed and hopeless. Often women will say, I feel lonely, even with the most amazing family support and social supports. And they might feel afraid. And very commonly what we see with postnatal depression is kind of a passive death wish. So women might express, for example, it would be so much easier if I just didn't wake up in the morning, or, wouldn't it be so much easier if like I was walking across the street and a bus ran over me? And it can be very scary to hear that sometimes from a woman, but it's something that you certainly do need to probe. And also, it's very different to someone expressing suicidal ideation where a woman is saying, I feel so unwell, I want to kill myself. I feel so unwell, I want to go and buy a rope, so it's quite different. So how do we screen for postnatal depression? Well, I'm sure you're all familiar with the Hooley questions. You know, have you been feeling down, depressed or hopeless? The Hooley questions are really good kind of starter questions to kind of open the conversation around depression and around mental health. The GAD2, so questions about recent symptoms of anxiety, can be helpful as well for opening conversation. The GAD7 is a bit more specific, and it would probably pick up a bit more in terms of maybe obsessional thoughts and the type of anxiety that women are experiencing. And I'm sure that you would be familiar with the Edinburgh Postnatal Depression Scale, which is a 10-item scale which screens for symptoms of depression and anxiety, and question 10 screens for self-harm. These screening tools or case finding questions are all really, really helpful for opening the conversation around postnatal depression, but they're not diagnostic. And we need to remember that. They can help to kind of normalize the process about emotional well-being. You know, we've no problem kind of asking women about their breastfeeding or the third-degree tear or how their wound is healing, but sometimes we can be a bit slow to kind of talk about emotional well-being. So I think going forward, you know, rather than relying on screening tools, we probably have to get a little bit better about using open questions to ask women how they are. And that is going to be done through obviously training and ongoing CPD, and obviously collaborating with other services. So as you know, in Ireland, the perinatal mental health services have been, I suppose, rolled out over the last number of years, and the model of care was established in 2017. And this really set a benchmark for the type of care that women in Ireland can receive. So we use a hub and spoke model. And what that means is that for the larger maternity services, they have a full perinatal mental health team. And then the spoke services, which are the smaller hospitals, will have a perinatal mental health midwife in each site. And what's absolutely fantastic now is that we actually have a perinatal mental health midwife in every site in Ireland, and that's absolutely fantastic news. Some of those midwives are literally about to go into post in the next week or two. So just to give you an example, Rotunda Hospital is a hub site where I work, and our spoke hospitals are Cavan General Hospital and Our Lady of Lourdes. So there's two perinatal mental health midwives in those sites who we would link with quite regularly. So this is what our team looks like in a hub, and I'm very, very lucky to be in a hub. So we have a full-time perinatal psychiatrist. We actually have two psychiatrists who work as half-time. We have one senior reg, and that role kind of changes every year. We have a senior psychologist as well, full-time. Myself, I'm the AMP on the service. We have 1.5 clinical midwife specialists, and we have 2 clinical nurse specialists. We also have a full-time mental health social worker and 1 full-time admin person. We do have funding as well for an occupational therapist, and hopefully later on this year we will have an OT within our team, which would be fantastic to do kind of parent-infant work with women as well. So perinatal mental health midwives. So this role has been rolled out nationally, as I said, as part of the model of care, but it's a new role in many services. It was established in the Rotunda back in the year 2000. So at the moment, as I said, some midwives are going into the role having a lot of experience in mental health, some having not so much experience in mental health. So the services that are being provided by the perinatal mental health midwives in the spokes might vary from site to site. But just an example of what midwives are providing is kind of antenatal and postnatal assessments, running their own clinics, providing psychoeducation to women and families. Some midwives are offering psychological interventions, group interventions in antenatal classes and that kind of thing, and also offering education and training within their maternity services. And they're very commonly linking with yourselves, the public health nurse, with GPs, with liaison community mental health teams as well. Okay, so what do we do if to try and support women who are experiencing postnatal depression? Well, we probably need to start, don't we, before the postnatal period, before the pregnancy, and perhaps preconception. But I think it's really important, even in the antenatal period, that we identify high-risk women. And of course, within maternity services, we're doing that. But trying to build up social supports for women, also for women, being able to identify the stressors in their life so that they can put some plans in place, maybe to try and manage those. And anxiety management is a really, really big thing. And I'm sure you're seeing this as well. So many women coming through our services are anxious now. And we've seen such a wave of that with COVID. So trying to use kind of techniques and tools to manage anxiety. I think the other thing as well is that, antenatal education really can vary. And, commonly in our society, we have this kind of Instagram view of pregnancy, birth, and motherhood. And it's not always realistic for women. And sometimes there can be a huge kind of mismatch between expectation and reality for women. So I think we do need to kind of keep it real for women. We need to include partners in group interventions. And we also need to sort of offer trauma-informed interventions to women as well. So for women with mild symptoms of postnatal depression, like all of these things are advice I'm sure that you would give to women every day when you're meeting women in their homes. The first thing I would always say, though, is ask the woman what has helped her before. Okay, so what resources do you have? What's helped in the past if you haven't been well? What kind of supports do you have? Okay, ask her what she has. But some of the very common things, and of course, probably the most important thing, is the social support, isn't it? So, the help at home. The help from the partner, the help from the family. And unfortunately, some women just don't have those supports. Exercise, completely underutilized, isn't it? I get a lot of women to download the Couch to 5K app, women with mild symptoms, and get them running, get them walking, get them out. Nobody feels worse after doing exercise, okay? And, running can be time efficient as well. You might have to take half an hour, 40 minutes, an hour to do a walk, but you could run for 20 minutes. And sometimes that's a bit more practical with a newborn baby. Obviously, keeping a healthy diet, yoga, mindfulness and meditation can be really, really helpful for mild symptoms, but also peer support, woman to woman support, and women really, really benefit from that. Listening visits, and I know some public health nurses might offer this. Baby massage can be really helpful as well. And some of the kind of home parenting programs that Better Finglas offer, like Preparing for Life, can be really helpful as well. There's lots of resources online now. So, for example, online CBT programs and motivational interviewing. So we can do that with women. It's about being kind of strengths-based and recovery orientated. And sometimes if somebody's feeling a bit low, that little bit of motivation from yourselves, from us, can be really helpful. For women with moderate symptoms, then you'd be looking at perhaps referring to the GP, to the specialist perinatal service, or to the perinatal mental health midwife. Again, focus on the social supports first of all. And certainly with moderate symptoms, antidepressant medication and or anti-anxiety medication might be warranted. Lots of women have huge conflict about taking medication if they're breastfeeding, but there's several antidepressants and anti-anxiety medication and sleeping tablets that women can take when they're breastfeeding. Listening visits, again, can be really helpful and very powerful for women. You don't need to be trained in psychotherapy to do listening visits. You just need to listen. Postnatal depression support groups, and we have worked with yourselves as public health nurses and also with other organisations in the community to try and get a postnatal depression support group up and running, and the women really, really benefit from it. It's fantastic. Psychological interventions might be helpful, for example, CBT or another form of psychotherapy. And again, using the motivational kind of interviewing, and you can do this with women, if somebody's feeling really depressed, flat and low, trying to get them to kind of make very small goals and build those up. What if we could kind of get you out walking 20 minutes a day, 3 times this week? How would you be able to manage that? And also for women with moderate symptoms, we might be looking at kind of parent-infant work. And we're very lucky now that we can link in with organisations such as Young Ballymun, who can do work on infant mental health as well. For women with very severe symptoms, you know, obviously they need to be referred to the GP, to the specialist service, and perhaps even to a community mental health team. Again, the social supports are so important here, but a woman also might need, you know, a number of medications, including antidepressants, perhaps antipsychotics, and admission often to an approved psychiatric unit. Unfortunately, in Ireland, we don't have a mother and baby unit. That's still some way off, but it is coming down the pipeline and it's very much needed. And also women might need kind of longer term psychological interventions. I just wanted to talk a little bit about cognitive behavioural therapy, because now I'm very biased because I have trained in this myself, but I suppose it's an intervention that I think as public health nurses could be really helpful for you working with women in women's homes, seeing women in the clinic. And really CBT is kind of the gold standard, according to the NICE guidelines, for anxiety and depressive disorders. You have a great therapeutic relationship with women and families. You're well placed, you're meeting these women. And a big piece of CBT is kind of psychoeducation, you know, helping women to make sense of their experience. You're targeting negative automatic thoughts. This can be delivered kind of as a one-to-one input, or it can be done as a group. And again, for the vast majority of women with the mild to moderate mental health problems, this is absolutely ideal as an intervention. And there's lots of kind of self-help interventions around CBT as well. I know that you're talking about advanced practice later in the day, but I suppose this is a role that I would really champion for public health nurses, because as I said, you're ideally placed with women and with families in primary care. And so perhaps developing a specialist or an advanced role in perinatal mental health, you know, could be the future. You could lead home visiting programs, postnatal and family-based interventions, and collaborate with ourselves in specialist services and with the GP and with kind of community mental health teams. You know, I've worked with public health nurses for a long time. I think you have a fantastic role, and as the speaker said at the beginning, I know since COVID you have had to wear so many hats and carried such a big load for everybody, but this is a role that I think that public health nurses could really champion as well. So thank you so much for your time, and I'm happy to take any questions. I'm sorry, I think I might have gone over on the time there, apologies. Sorry, I couldn't hear you, Liz, sorry.
I'm sorry about that. We've got a lot of questions here today because this is such a hot subject, as we know. So I'm going to try and put a few of them together for you to make it easier so everybody keeps nicely involved. First of all, the post-traumatic stress disorder, as we know, usually it's about 6 weeks after delivery before that will really be diagnosed. But we're just wondering, due to the isolation within the wards and at delivery for mums from partners, husbands, have you found that there's been an increase in post-traumatic stress disorder due to this fact alone?
It's a really interesting question, and it's a really important question. You know, certainly what we are seeing is women who have really struggled with isolation, being separated from their partners, being anxious in pregnancy because they don't know if when they come in labor their partner is going to be with them. I mean, absolutely, there is no doubt that that has impacted women. Whether we're seeing more post-traumatic stress disorder, I don't know. Certainly we're seeing lots of post-traumatic stress symptoms, which we do, but to actually meet the diagnostic criteria for PTSD, you know, is quite difficult actually. And what we do find for women who might have had a traumatic birth because they were separated from their partner or for whatever reason, that some of those women will have post-traumatic stress symptoms. We started a clinic, actually a dedicated clinic in the Rotunda for this. So it means that we can identify women early. So I would say at this point, probably difficult to say if it has gone up, but certainly it has impacted women, definitely.
Okay, thank you for that. There's also the fact that, as you've expressed there, women are nervous, anxious and afraid to take medication, you know, to help with their symptoms, just to give them symptomatic relief, be it just sleeping tablets, because as we know, sleep deprivation is the worst thing that can happen to anybody, whether you've just had a new baby or just in general life. So it's kind of dispelling the myth behind taking medication. And should this be implemented or educated possibly throughout the whole pregnancy for women who would have suffered with postnatal in the past?
Absolutely, yeah. And again, I suppose it's something that we need to normalize going forward. You know, lots of women, when they find out that they're pregnant, will abruptly stop medication if they've been on an antidepressant or an antipsychotic medication. And what we know is that for about 68% of women who stop medication abruptly when they find out they're pregnant will relapse in pregnancy. So the risk is always there. So we try to bring it up in antenatal classes, and again, just to normalize the process, because as you said, women have huge conflict around being on medication. You know, women would have no problem taking insulin in pregnancy, or if their blood pressure was high, taking labetalol, but they have huge conflict about, you know, taking an antidepressant. And again, lots of them are very safe to take in pregnancy. And I suppose it's about informing women and making that kind of risk benefit analysis so women can make informed decisions. We spend a lot of time as well kind of with GPs, educating them as well about kind of psychotropic medications in pregnancy and postpartum as well.
Thanks very much for that, Ursula. As you know, this is a real pet of mine. I love all the interventions and all the help that we can do. Give our mums, obviously due to the isolation, we had to stop our baby massage classes. We had to stop all our one-to-one contacts, but thankfully the therapeutic collaborative approach postnatal support group run with the Rotunda and Better Fingers and ourselves has shown to be fruitful for everyone. I now have to close it at that, and thank you so much. Any further questions, we may pass them on to you for answer, we'd love to have that opportunity.
Thanks a million. Thank you.